Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thanks for tuning in to the latest edition of The Checkup. Even as the COVID 19 vaccines roll out and we see a potential light at the end of the tunnel, there's still obviously a lot of concern for the long-term impact that the virus has on patients. Last May, Mount Sinai Health System in New York became one of the first in the nation to open a post-COVID clinic, offering care for those so-called long haulers. I'm pleased to be joined today by Mount Sinai President and CEO, Dr. Kenneth Davis, to talk about the process of standing up those units and caring for these patients. Dr. Davis, thanks so much for being with us.
Pleasure to be with you.
So let's talk a little bit first about Mount Sinai's decision to open one of these clinics up. Back in May, we were sort of at I guess, still the early stages of the first surge. What went through your mind as you were looking at standing up this COVID recovery center?
Well, it was early for the country, but it wasn't early for New York City. Our peak had happened actually, weeks earlier. The peak of it for the Mount Sinai Health System, which is 8 hospitals, we had 2,200 patients with COVID in the hospitals. We had opened up a lot of beds, enhanced our ICU capacity, but we were really, really swimming in COVID patients. So by the time May rolled around, we had already had a number of people who were, quote, recovered, but they still had a lot of symptoms. And we realized that those symptoms were debilitating in some instances, certainly compromising their life, and that we needed to address them. We needed to address them with frontline internists and then with backline, behind them, specialists that we'd refer to. And to date, we have seen 8,000 COVID patients now in our hospitals, and we've had 20,000 COVID outpatients. So between those nearly 30,000, we have a substantial number of people who have chronic symptoms.
And are there specific things that you saw early in the stages of COVID that were lingering in these patients?
Well, you'd see a lot would complain of fatigue. A lot would still have shortness of breath. But of course, it wasn't just a lung problem. The more we learned about it, the more we realized it was also a kidney problem. It was also a brain problem. It was a cardiac problem. So depending on the symptoms that people had, there were any number of organ systems that could be affected that we needed to address.
And how did you staff it then? Because I'd imagine and still staff it. You have staff that are so spread so thin these days. How are you managing that process?
We're integrating it into our other clinics. And we have a lot of our primary care people and our internists who want to be there. So, staff is being thin. We're making them do lots of things. But this hasn't been something that has been hard to staff. There's just a lot of people who really want to help.
And is there cross-training that you need to do?
It's mostly about making the right referrals to the specialists who are necessary, because the symptoms that people have aren't unique. If they're congestive failure problems and cardiac problems, we know them. We know what to do with them. If it's depression, we know how to deal with that. If we're developing end-stage renal disease, it's just like any end-stage renal disease. We know how to deal with these bad consequences. We just don't understand exactly what their prognosis is and why some people get them and other people don't get them and how long they're going to last.
Yeah. If you, knowing what you know now, if you could go back to May, what kind of changes would you have made standing this recovery center up?
Well, we need to be in contact with patients. So we really would like to have said ahead of time, this could happen to you. And when it does, here's a phone number to call, or here's an email, or here's a text, because we're there for you. That would have been the biggest thing we'd like to do, because a lot of people just don't know what to expect. And to be able to communicate that what you're experiencing now is not unique. And if you're depressed, it's not because there's something wrong with you. it's what happened with COVID to your brain.
You've referenced that depression mental piece a couple times here. Was that a large segment of what you were seeing in patients? Was that anxiety,
I, I
depression,
think
mental?
I think we're seeing the whole spectrum. It's not surprising when people still complain that they have some shortness of breath and fatigue. I mean, that could be lung, that could be cardiac. That doesn't surprise any of us. And with that, you may feel depressed anyway.
Hmm.
So whether it's COVID in your brain that has triggered some biological mechanism, or the stress of now being chronically fatigued, or finding out that your kidneys don't function the way they used to, it can be depressing.
Sure. Yeah, we all know people. I'm sure we've all been touched by people who are recovering, and have trouble even walking a block now because they're still recovering. So, what role are you, or what are you seeing in terms of helping those patients just start to build up their strength again?
It's it's some of it is rehab. It's getting people to do a little more every day. Some of it may be pharmaceutical, that we really have to enhance their cardiac capacity with drugs. So everybody's unique.
Okay. We talked a little bit about the clinical operational. What about the financial challenges you faced? Obviously, this
Well,
probably put a
financial,
strain on you.
financial challenges have been enormous, not from this chronic long hauler clinic, but from what happened in general.
Hmm.
Uh, Very early on, our governor, who's been terrific, told us, I want you to increase your capacity by at least 50% or even 100%. So it was early on. We were able to find per diems. Of course, they're very expensive. We were able to add beds everywhere. So we had staffing. We had to buy lots of equipment, um, and expenses just skyrocketed. On the other side of that, our Department of Health and the governor canceled all electives. And people were afraid to come to the hospital anyway. So what we had was a real fiscal challenge. Had it not been for the CARES Act and the money that we ultimately received, it was an enormous fiscal challenge. Imagine some of your highest margin stuff doesn't come, orthopedic surgeries. People can delay those. And then there was the debate about what is truly elective and what isn't elective. If you have, Gleason stage 7 or 8 prostate cancer, should you wait a month? Can you wait 2 months? Should you get that done right away? So we had a fiscal challenge, and it continues. And now some of our challenges, as we're seeing what we hope won't be anything like the first wave in New York, but we're seeing, gradual increases, is that staffing shortages occurs across the country. So whereas before it wasn't that hard for us to find per diems, now our challenge is to convince our nurses to take an extra shift at a bonus, to buy out their vacation, to keep people on the staff, and to deal with the question of what happens when they get exposed to COVID. What is the appropriate amount of quarantine? Is there a way that we could be, through testing and watching their symptoms, still have them working instead of sitting at home for 14 days asymptomatic, and before we had a lot of testing, all negative? So the challenges are enormous.
That question of staffing has come up time and time again for folks. Obviously, now that we're into this second, third wave, whatever we want to call it here. Do you see the vaccine as being a light at the end of the tunnel, and how long will it take for that to really take hold?
Well, clearly the vaccine's a light at the end of the tunnel. And clearly there isn't enough vaccine to go around. And everybody wants it. So that I am inundated with calls and emails and texts from various people in various capacities, asking, begging that they can get at the front of the line. But we have strict prioritization. For our 8 hospitals, we got about 7,000 doses to start with. We have about 14,000 workers right now who are on front line. And that leaves some 28,000 who don't understand why they're not getting it.
Right.
And then we have to make decisions about at-risk patients. There are people who already have some of the underlying conditions that would be made a whole lot worse by the chronic COVID consequences. So what do you do? How quickly should you vaccinate, a 55-year-old who is got 20% normal renal capacity so that they don't need dialysis down the road, or people who are already in some level of congestive failure, but are able to function with medications, but if they got COVID, they're disabled. So we're going to need some more flexibility around how do we use those vaccines? Where do you put a person who is at tremendous risk versus a person who appropriately is working in a grocery store and is also seen as an essential worker? These are very difficult decisions that we're having to make.
Well, and it's interesting too, as we started out talking about the long haulers and what you kind of referenced there, the research, it sounds like that's still needed to know how to prioritize people with an underlying chronic condition versus someone who doesn't have that.
We just don't know. We are started a longitudinal study where we've so far already entered 500 long haulers who we hope to study regularly and potentially for years to figure out what was their prognosis, what did work, what didn't work, so that we can learn from this.
And will your long hauler work, is that fully integrated into the rest of Mount Sinai at this point, or is that still a work in progress?
Fully integrated.
Okay. And so if you were talking to peers who are beginning this process of standing up a long haul clinic, what are the first 2 or 3 steps they need to take?
Identify some doctors who are comfortable taking care of those people, and then identify those patients who really need it. Reach out to those people and try to get them in so that you can begin to do what we really need to do. Let's give some of these people hope.
Yeah. Have you run into challenges on the payer front of them, willing to pay for some of the treatment you're doing in the long haul clinic?
There are always challenges with payers, but I don't know that these are going to be any worse than anything else. We'll see. The part of the business model of some of the insurance companies in the last few years has been increased number of denials.
Yeah.
And working vigorously and rigorously to try to deal with that problem.
I guess lastly, on this front of the long haulers, as patients start to get more comfortable seeing their primary care practitioner, what role will they play in being able to help manage some of these long haul conditions?
I think we ultimately have to hand off the long haulers to their internists, their traditional doctors, and work in concert with them.
And do you think these types of symptoms will last a year or 2 years, or we just don't know?
We've had some who've gone only a month, some 6 months, and some still from when they contracted it in March.
Interesting. Well, we'd love to stay in touch as you continue to work and help these patients. We know it's a busy time for you, but we greatly appreciate you taking the time to talk to us about your post-COVID clinic.
Thank you. My pleasure.
Thank you. Thanks. And I'm Matthew Weinstock with Modern Healthcare. Be sure to come back next Monday for another edition of The Checkup.